Okay, so this is being recorded, so I'm going to try to not be a comedian and be very, very professional. So, so this is our Stericycle's Pharmaceutical Waste Program training specifically for Erlanger. There are several programs that Stericycle has. I don't know if any of you remember, but several years ago, you guys had multiple colored containers and it was very confusing on what went where. And so we condensed into one black container with some caveats to that. And so that's what we're going to be talking about today. If anybody has any questions, feel free to stop me, raise your hand, ask a question. It's perfectly fine. So again, this is basically to let you guys know, as Seth said, nothing really has changed. This is just a refresher course to kind of let you know what we're going to be discussing with nursing going forward, and then how that's going to pertain to you. As he said, some drugs might be coming back to the pharmacy that may not have been coming back before. So this is really a train it forward program for the clinicians, so that nurse managers, directors can take this back to their staff and help them ongoing know what to do with the pharmaceutical waste. So Dee is our healthcare compliance specialist. She works with the hospital on compliance. She does compliance rounding. She provides reports to let Erlanger know the good and the bad and the ugly about the program. And so we decided that it was time to kind of do a reset. We've got different leadership now in pharmacy and at the hospital within the last year. And so we wanted to do this reset to get everybody back on the same page. So first of all, we're going to talk about why Erlanger, or any hospital for that matter, needs a pharmaceutical waste program. And the simple answer is it's because it's the law. There are, as you can see up on the screen, there are multiple regulatory agencies that have to do with regulating pharmaceutical waste. The main one is the Environmental Protection Agency, the EPA. There was in 1976 a law that came into play called the Resource Conservation and Recovery Act. And that actually came into play to regulate large industry and the amount of chemicals that they had. So when you fast forward to today, the regulations really have not changed, and they really have not been detailed and tailored to fit hospitals. So some things you think, when I talk up here, you're probably going to think that makes no sense whatsoever. And that possibly could be very true, but we have to make it work in the hospital setting. We also have state agencies that are involved. So TDEC, the Tennessee Department of Environmental Conservation, is basically the state EPA. They also regulate what happens to the pharmaceuticals that leave the hospital. The Department of Transportation regulates the pharmaceuticals as they're being hauled by Stericycle. The DEA regulates the narcotic waste. And then also the Joint Commission, even though they're not a regulatory agency, they have a standard that basically says that you have to, hit their standard for performance for proper management of hazardous materials. And pharmaceuticals fall into the hazard material category. So this all started with, like I said, in 1976 with the RCRA Act, but they started enforcing this at hospitals early in the 2000s, because what they did was there was a U.S. Geological Survey done, and what they found in 80% of the streams that they tested, they found all of these adverse effects from drugs that had been flushed down the toilet or poured down the drain. Some of those things were antibody resistance to the fish. There were fish that were, male species that had turned to female. There were all kinds of things that were going on. So they said, well, if that's happening to fish, then we don't want that to happen to people. So then the media got a hold of it and it kind of exploded. And the next thing you know, hospitals were under the microscope. When the EPA or TDEC does an inspection for your pharmaceutical waste, they can impose fines. The largest fine that we have seen in the last few years has been almost $500,000, and that was for improper segregation and labeling of hazardous pharmaceutical waste. So that is why we feel it's so important to make sure that we do a pharmaceutical reset and everybody's on the same page so that that doesn't happen at Erlanger. So what is pharmaceutical waste? Not everything, not every drug that is used is pharmaceutical waste. Just because it's a drug doesn't mean it has to go into the container. The only thing that has to go into the container is leftovers. And what we mean by leftovers is if it is more than 3% by volume. So no one has time to sit around and measure a vial or a bag to see if it has 3% of the total contents. So you have to kind of follow the common sense rule of thumb. If there is something that can still slosh around in the bag or in the vial, then it is waste. If it's just bubbles or residue that's left, it is trash, and it can go into the municipal solid waste. Unless it has HIPAA information, and then you would need to take that label off or black it out or do whatever your hospital policy is for that. So basically, if a drug has been used for its intended purpose, if you cannot return it to a distributor for credit, and that you've determined that those two things can't happen, and that it is more than 3% by volume, it needs to be discarded as pharmaceutical waste. Does anybody have any questions about that? So let's pretend like this, let's pretend like that this bottle is half full and you're not going to use any more of it. That would be waste. If I drank this bottle, you know how the bottom of a water bottle has these little indentions and it kind of, some residue sits down in there and there's some bubbles. If you saw the bubbles down there, that would be, it's been used for its intended purpose. You can throw that into the trash. It is not pharmaceutical waste. So again, examples would be partial vials, drugs that are not dispensed, pre-instilled IVs with something left over, pre-filled syringes that have something left over. I'm not going to read all of these things, but if it's left over and it's enough to where you think, oh, somebody could get a hold of that, or there's enough that somebody could get something out of it, then it needs to go into the pharmaceutical container. These are things that will not be, should not ever be disposed of into the pharmaceutical containers. However, we do see this all the time from nursing, and so this is why we're going to be stressing this with them also, because since some drugs will be coming back to the pharmacy, we don't want you to deal with any of these improperly packaged items. So one thing that should not ever go to a pharmaceutical container is regulated medical waste. Anything that's contaminated with blood or body fluid. Those should always go into a red bag container or a Sharps container, but medication should never go into a Sharps container. So again, empty things, you should never see empty vials coming back. You should never see anything like that that's empty coming back to you, because we're going to stress to the clinicians that if it's empty, it's empty. Now, there's a couple of caveats to being empty, and we're going to discuss that in a minute. Plain IVs. Plain IVs can be slit and poured down the drain. There's no reason that plain IVs should be put into the pharmaceutical container. They don't have any medications in them, so they don't count as a pharmaceutical. They're just plain IVs that can go be slit, poured down the drain, or into the toilet. And then controlled substances. So right now, Erlanger uses Stericycle's controlled substance program in the ORs. And I know that you guys have just started a controlled substance program on the floors. And so controlled substances cannot, under any circumstances, go into a black pharmaceutical container. And here is why. You have to be a registrant of the DEA to haul narcotics. there are no regulated waste haulers that have that license or certification. So if someone puts a half bottle or a half vial of morphine in one of our sharps containers, the hospital and Stericycle is out of compliance as we transport that waste down the interstate. So that is very important that narcotics go into the right place. So now we're going to talk about how do I know where they go? And like I said before, several years ago, you had a blue container on the floor for non-hazardous. You had a black container for hazardous. And it was very confusing, and there was a lot of non-compliance. And so the hospital decided at that time, let's just condense and let's just treat everything as if it were hazardous to make it simpler for everyone. So we have certain waste codes. If you ever look at one of our containers, you will see on the front of the black container, it says BKC. That means it's a black compatible. It's a black container and it's compatible. That means anything that's doesn't have something special about it can go into that container. And then we have sort codes that start with SP. And since you guys are all from pharmacy and we've been talking about sending drugs back to pharmacy, what do you think the SP code means? Anybody? About send to pharmacy. That's what SP means. Okay, so we've got SP, regular SP is for like an inhaler, an aerosol, maybe hurricane spray, albuterol that hasn't been completely dispensed. That might come back to pharmacy. We have SPC, that means C means corrosive. There's very, very few corrosives. Robenol, glycopyrrolate, lactic acid, things like that. Again, this is only if it's left over. So you should see these things coming back to pharmacy very infrequently. SPO for oxidizers. One of the biggest examples of an oxidizer would be a silver nitrate stick, but that would be only if that silver nitrate stick was unused. So if I was a nurse and I dropped it on the floor before I used it, it has not been used for its intended purpose, so it would be waste. At that point, I'd put it in a Ziploc bag and send it to pharmacy. If I used it, it's been used for its intended purpose and it can go into the trash. We've got a special code, it's SPLP. That will be used very infrequently. That's something like Botox. So if somebody, there's a special floor that uses Botox, we would want to talk to them specifically about where in those areas, Seth, where Botox is used. But it would also come back to pharmacy. What that means is that it has to be packaged specially in order for it to be transported per the DOT. So what these codes mean is when I'm a nurse and I am in the electronic dispensing system and I'm going to pull up silver nitrate, what Seth is going to ensure is that these codes are in that system. And that's going to pop up and that's going to tell me that that code is SPO. So if I have that silver nitrate stick left over, I am going to have to know to put it in a Ziploc bag and send it back to pharmacy. So what's going to happen is the only codes that are going to be in the system are send to pharmacy codes because everything else is going to go into a black container except for the very last one, which is the P code. P is for P listed waste. P listed waste is considered to be acutely hazardous waste by the EPA. So acutely hazardous that even its packaging has to be captured so that the environment is not contaminated. So that would be warfarin, Coumadin, arsenic trioxide, and the blister packs that they come in. So if I'm dispensing Coumadin and I pop one out of the blister pack, that blister pack, when it's empty, also has to be captured. And those are also going to come to pharmacy for disposal. The reason that that collectively, Seth and Katie and Dee and I have talked and decided that the best thing to do is to send these items back to pharmacy is because number one, they happen very infrequently. Maybe 1% of the time they're going to come back and there's going to be something left over. And number two, because of the potential of non-compliance, to have multiple containers on the floor, the more containers you have, the less compliance there's going to be on the floor, especially now that nurses are so busy, understaffed, overworked. We just would never be able to get them to put the right thing in the right container. Does anybody have any questions so far? So what you're going to see out on the floors, if you're out on the floors and also in the pharmacy, you're going to see our black containers sitting in the dolly. You might see the small 2-gallon container that holds, that can also accommodate needles and syringes if there's something left over in a needle or a syringe. And everything's going to go in this black container, except for those items that are infrequently going to come back to pharmacy, which again are the corrosives, the aerosols, the P-listed waste, and the oxidizers. Those are the things that you're going to see. So if, I'm not sure how the system works, but if you have someone that goes to the floors and collects things to come back to pharmacy, you might see a Ziploc bag with an aerosol in it, with an inhaler or hurricane spray or albuterol. And when that went back down to pharmacy, you would know that is an aerosol, and it would need to go into the container that's marked aerosol. And that is basically the pharmacy's only responsibility, is to make sure when it comes back to you that whatever it is goes into the right container. And you will have those containers in the pharmacy. So again, we've kind of already gone over a lot of this. So what goes into the small little black containers, that is actually a sharps container. It's a black sharps container. And when you see that, one more. When you see this one, that means that if you draw something up and for some reason the nurse can't give it, patient refuses it, for whatever reason, there's something left over in that syringe that still has a needle, it would go into this black small sharps container. The one that sits on the floor is not a sharps containers. That's for larger bags, vials, etc. So again, things that don't go in this black container, controlled substances, free-flowing liquid. We don't ever want anyone to shoot the drugs into the container. We want the whole needle and syringe to go into the container. We don't need empty needles and syringes in there because that would just make it overflow. And we don't need empty wrappers or packaging of any kind. So I'm going to go back to the listed waste. When I mentioned P-listed waste again, there are two types of waste that are listed. If you go to the EPA website and you type in listed waste, you would see a P-listed waste and a U-listed waste. The P-listed waste, again, is what we've already talked about: the Coumadin, warfarin, nicotine patches, arsenic trioxide, epinephrine, nitroglycerin. And then the U-listed waste is chemotherapy waste. Then you have your character. Yes, Seth. Yes. And there are some state-specific regulations that we will go over with you specifically, to make sure that you know exactly what, because there are some changes coming to the regs in Tennessee. We don't know when, so we don't want to get too specific today. So the other type of waste are characteristic waste, and those are the ones that I've been talking about that are going to come back to you. And the reason they're characteristic waste and you can't just mix them all into the same container with the majority of the other waste is because they have a characteristic that's going to make them react with something. It's going to make them toxic. It's going to make them catch on fire. So the Department of Transportation doesn't want you to mix those types of waste and then some kind of fire start in the truck when the truck's going down the road. That probably would happen very infrequently, but it has happened before. So it's mostly for safety purposes. All of these types of waste, the oxidizers, the corrosives, the aerosols, they can only be mixed with themselves. So that's why they have to be put into come back to pharmacy and only be put into their specific container. Again, we've already talked about the SP and the SPC and the SPO codes. So we just did a new formulary characterization, and that basically tells us all of the drugs that you have in your formulary or in inventory, and it has all the codes attached. And then Seth will be working with someone from the pharmacy to make sure that all of these send to pharmacy codes are in there. Typically, if you had a different program, we would have the BKC, which means black compatible. But because everything's going into a black compatible, we don't want to confuse people with more codes. So the only codes that will exist at Erlanger are the ones that say, hey, nurse, if you have something left over, send it back to pharmacy. What they're going to do is they're going to put it in a Ziploc bag, put it into the return to pharmacy bin. It'll come back to you. And then that way you guys will know which container to put it in the pharmacy. Again, this is not going to happen every day. It may not happen every week. It's going to happen only in those rare instances when they have one of these types of incompatible drugs left over. So let's talk a little bit more about P-listed waste. It's kind of confusing because we say empty is empty. I talked about the enough left to slosh around in a container, except for P-listed waste. So when you think of P waste, it's acutely hazardous. And I always try to associate the letter P with packaging to remind everybody, if you see a P code, that means that not only the leftover drug has to be disposed of and sent back to pharmacy, but also its packaging. Not the cardboard box that the blister packs come out of, but the blister packs that have actually touched the actual drug. The EPA says those cannot go into the trash. Again, the nurses will put those blister packs and even like the little cups that they put the pills in to take to the customers, those would have to be captured as well, because the residue from that pill could be on that little disposable cup. So anything that's touched that drug would have to be put into a Ziploc bag, sent back to pharmacy. So I will tell you that probably the majority of the things that you will see coming back should be P-listed waste and the packaging. That's what you're going to see the most of. So on top of everything we've already talked about, as if it's not already confusing enough, we also have chemotherapy waste. So we have trace chemotherapy waste and we have bulk chemotherapy waste. Bulk chemotherapy waste is chemotherapy that's left over. So if you have a bag, you hang it, the patient can't tolerate it, the patient expires, the doctor comes in and says the patient can go home, they don't have to finish it, and you have half a bag left, that is bulk chemotherapy. It's hazardous because it's greater than 3% by volume. If you have a bag that's been hung, it's completely been instilled, it's done, there's only bubbles left in the tubing, there's only bubbles left in the bag, that can go into the trash. It is not pharmaceutical waste because it's not greater than 3% by volume. Bulk chemotherapy waste has to be treated as hazardous pharmaceutical waste, and trace chemotherapy waste is treated as regulated medical waste. The bulk chemotherapy waste is incinerated at a hazardous waste incinerator, and the trace chemotherapy waste, which would be all the PPE that's used to administer chemo, gloves, gowns, anything that the drug has touched that goes into the large yellow. The large yellow containers are collected. They are packaged as regulated medical waste, and they are also incinerated, but at a lower cost at a medical waste incinerator. Yes.
We also have yellow bags.
Yes.
They go in cardboard boxes. The only difference between the yellow hard side bin and the yellow bags is that only sharps can go in the yellow bins, is that correct?
So the question was, Erlanger uses yellow bins and also yellow bags. And so what can go into which one? So the soft waste should go into the yellow bag. So the PPE, things like that. And then everything else, the empty or the empty things, needles, leftover vials should go into the yellow container. However, if the yellow container gets used for PPE and things like that, it's perfectly acceptable. It's just a very expensive process because those yellow sharps containers are expensive. So the answer is basically you just don't want the chemo sharps to go into the bag. Okay. So we want to make sure that the pharmaceutical waste gets into the right container. So on those floors that do infusions, they give chemo, we want to make sure that they have the yellow containers for the trace that's less than 3% by volume. We want to make sure that they have the black containers for the bulk, which is greater than 3% by volume. And we want to make sure that they're always closed whenever they're collected. So when Stericycle technician comes around to change out the sharps containers, we also exchange the pharmaceutical containers. So during their route, they're on route every day through Erlanger, and they see that a pharmaceutical container needs to be changed. They pull the bag, or they take the container, leave a new container, and then they pull the bag from that container and package it for transport in a central accumulation room. So what you don't want to do is if you ever go up on the floors and you see the pharmaceutical containers that are open because it's more convenient, just close those. We want to make sure that they're closed at all times. They're in nursing areas. They should be in secured areas so that someone can't just walk into an area that's not locked or secured and think, oh, there might be some good drugs in here that I can pilfer through and get. So those really need to be under the watchful eye of a clinician. So actually the med rooms or near the Omnicells or Pyxis, whatever you guys have, is the best place for those. Again, we do exchange your pharmaceutical waste. If you ever have a problem, or if you see that the tech is not coming to the pharmacy to change your containers, you want to let us know. I anticipate that you guys probably will start filling some containers more quickly once we get this rolled out to nursing and we get everybody back on the same page. But again, I think the majority of what you will see will be P-listed waste. So if for any reason in the pharmacy, you have a container, let's say our technician comes at 7 o'clock that morning, okay? And by that afternoon, for some odd reason, you're doing some kind of special infusion or something, and you filled up a pharmaceutical container and you need it changed out, and we're not going to be there till the next day. Environmental services is always our backup. So if you ever need something while a Stericycle technician is not on site, then you can call environmental services and they will change your container for you. So once we get it packaged, we package it, we label it, we make sure that it is packaged compliantly. It's labeled and packaged, we manifest it and we ship it, and then we send back a final manifest that shows that the waste was destroyed. So again, I just want to reiterate that this is really, even though it's a waste program, it's really a clinician waste program because they're the ones that are generating this. Your job, basically, is to receive the waste that can't be mixed together in the containers on the floor, and then put that waste from a Ziploc bag into the proper container. You don't have to undo the Ziploc bag to take out the waste. You just drop the Ziploc bag directly into the container that it goes to. Does anybody have any questions? Yes, ma'am. Okay, question was, where do liquid narcotics waste go? So in the pharmacy, you do not have Stericycle's narcotics waste program. We only have our containers in the ORs. Recently, Erlanger implemented their own program. I believe that Sodexo put that together. You should have one of the containers that they have designated for narcotics waste. If you don't, I would reach out to someone in Sodexo, to Steve Wheeler or to Mary Rohde, and let her know that you guys do not have the proper containers. Okay? Anything else? Seth? In Stericycle's containers, yes. And I don't know about the program that the hospital and Sodexo. So for our containers, I'll just give you a brief overview of Stericycle's container. It's a 1 gallon or a 3 gallon container. The lid is completely molded onto the container, so no one can remove the lid. At the top of the container are holes so that you can squirt the narcotic and it will drip through the holes. There is a slit in the center for nicotine patches. And then inside of the slit, there's a round part for pills and tablets. Inside the container are carbon pods that kind of look like what you put in your dishwasher. They're carbon pods. When the liquid hits the carbon pod, the carbon deactivates the chemical that makes it a narcotic. And so also inside there is another pod of Bitrix. Does anybody know what Bitrix is? What Bitrix does? No? So they use Bitrix in antifreeze, so that if anyone tries to drink antifreeze, it makes them vomit profusely. So even though in our container, you would be deactivating the chemical that makes something a narcotic, someone still might get the bright idea to rip that off the wall and turn it upside down and drink it. Stranger things have happened when it comes to narcotics. So the Bitrix is in there. It also dissolves. And so if someone were to do that, they would get a really nice little trip to the ER because they would be very, very ill. So with our program, we take those containers. Our technicians would also change those out as they're changing the sharps and the pharmaceutical waste. And then we send those off, and before we send it off, we solidify it so that everything inside of it is solidified. There's no more liquid, and then we incinerate it. So there is no trace of it coming back to Erlanger. You know, somebody threw something away improperly, and you just don't want your name on the front page of the paper. So we feel that it's a best practice to incinerate the narcotics waste. Any other questions? No? Okay, we're gonna have another session this afternoon and another in the morning. If you have questions, please direct them to Seth. He can direct them to us. We're going to be going house-wide with training for clinicians over the next 4 to 6 weeks. And so hopefully after that, everyone will be on the same page and there won't be as many questions and as much ambiguity about the pharmaceutical program. So thank you so much for your time and have a good afternoon.